Welcome back. This is Ian Bodford.
And Liang Lu.
And this is the clinical correlation.
Our next case is...
This patient was a 70-year-old male with a past medical history of hypothyroidism and asthma who presents to the ED via EMS after being found unresponsive under a bridge.
So from the EMS report, it looks like he was triaged as a drunk who urinated on himself.
Indeed. However, on assessment, the patient was noted to be bradycardic, cool to the touch, and somnolent to the point where he would only arouse to sternal rub.
It is important to note that the outside temperature was a warm 80 degrees.
Here were his vitals. He was bradycardic to 47. It was difficult to get an accurate temperature, so a rectal thermometer was used and read 29.5 degrees Celsius.
I'm sorry, are you saying he was 85 degrees Fahrenheit?
Yeah, he was cold. That's not all. Check out these legs. His chart mentioned chronic skin changes, and he definitely had them. His legs were discolored, rough, cool, hairless, with multiple healing ulcerations.
Looks like pretibial myxedema. I bet it was non-pitting edema at that.
Needless to say, we started a broad workup for this guy, including looking at toxic ingestions, withdrawal, and sepsis. Due to his history of hypothyroid, TFTs were also sent.
Aside from the marked bradycardia and prolonged QT interval, on EKG he also had very interesting findings. And although the EKG machine spells it incorrectly, it actually picks up on the Osborn waves. These are most notable in V4 and V5.
Osborn waves are also known as J waves, or camel hump sign. These are positive deflections of the J point. However, the deflection is negative in V1 and AVR. They are usually seen in the precordial leads.
If seen on the board exam, the answer is hypothermia, typically less than 30 degrees Celsius. But this is not pathognomonic. In hypothermia, the height of the J wave is roughly proportional to the temperature.
But keep in mind, it can also be a normal variant related to hypercalcemia, caused by medications, or a sign of neurologic insult. So if your patient has Osborn waves, but they are not cold, keep a wide differential.
His lab work returned, and most notable was a negative tox screen, as well as a negative alcohol level. His white count and lactate were also normal.
What was abnormal were his thyroid function tests.
Wow, he's got Myxedema Coma. Let's talk Myxedema Coma. Patients come in with altered mental status, with confusion, and potentially in a coma. Most patients are older than 60 years of age.
As in our patient, they will typically be bradycardic and hypothermic with a constellation of clinical signs including coarse hair, periorbital edema, goiter, macroglossia, and delayed deep tendon reflexes.
They can also have respiratory failure, both from central hypoventilation and from airway obstruction from the swelling of their tongue or glottis.
Always include Myxedema Coma in your differential in a patient who has hypotension refractory to vasopressors.
There are a number of potential precipitants for Myxedema Coma. Any type of heart disease, including CHF and MIs, stroke, environmental exposures, including burns and hypothermia, medications, or lack thereof when it comes to their thyroid medications, any major traumas, infections, or electrolyte abnormalities, including hyponatremia or hypoglycemia, can precipitate Myxedema Coma.
Really, any insult to the body's steady state can be an inciting factor.
The initial job as an ED physician is to assess the ABCs. If your patient has impending respiratory failure, do not be afraid to intubate.
IV fluids should be started because these patients are usually volume down. Make sure to correct for electrolyte abnormalities with your fluids. The one caveat is to not correct their hyponatremia too quickly to avoid myelinolysis.
As always, treat the underlying condition, whether it's starting antibiotics, warming the patient, etc.
Get your endocrine specialist involved early on these patients, especially when it comes to dosing the IV levothyroxine.
If there is any concern for adrenal insufficiency, start high-dose IV steroids. Remember that vasopressors usually do not work until levothyroxine has been started.
These patients will almost always be admitted to the ICU as mortality approaches 60%.
The patient was admitted to the medical ICU with endocrinology following. Hydrocortisone and IV levothyroxine were started.
Within a matter of hours after the medications were started, his bradycardia and hypothermia resolved. After all cultures returned as negative, his antibiotics were stopped. After 2 days in the ICU, he was transferred to the floor and discharged home on hospital day 5.
So in summary, make sure to respect the thyroid. Yes, an out-of-control thyroid can kill your patient.
Remember that we are first and foremost resuscitationists. Don't be afraid to intubate the patient if need be. Take care of the ABCs.
Look for Osborn waves in your patient with hypothermia, but don't wait for the EKG to diagnose a cold patient.
And finally, think of the thyroid in patients with refractory shock or altered mental status. Get your endocrinologist on board and start levothyroxine and steroids early, as these are what will save the patient's life.
So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com. And don't forget to follow me on Twitter @MDNotified.
Thanks for listening.